So, Alison, thank you for agreeing with me. Thank you for agreeing to talk with me, even. That's a great start, isn't it? So, you are a health psychologist and one of my brilliant associates at Blue Tiger. Um, let's start with where you're at the moment, what a typical week looks like, because I know that you do some different things on different days. So, let's start there and then jump back to how it all started.
I do indeed, yeah. So I think one of the things that I've been working over for the last couple of years is trying to get some real nice variety in my week. So I feel like I'm at that stage now, which is nice. So at present, 4 days a week, I work within the NHS in Scotland, and I work in a forensic mental health hospital where I am a health psychologist. And I guess within that role, I'm working with patients who experience severe mental illness, things like schizophrenia, psychosis, kind of some people, and usually alongside that, people have come to us because they have got a history of violence and offending, and I work specifically with them and focusing on their physical health because unfortunately within that population and that group of people, there's quite a significant health inequality. So they often experience a high burden of physical health conditions, long-term health conditions, and kind of things that things that might not be ideal with their health. And so I work with them to understand that, adjust to that, especially within the context of mental health care and their kind of mental health diagnosis, and to try and improve their quality of life as they progress through the mental health system, or for some of them return to prison. And then for the last couple of years alongside that, I've also worked within private practice. And for that, mainly, I guess I have a focus there in kind of, I guess, the general focus within that would be clinical health psychology. And by that, I mean thinking about, again, psychology within the context of, I guess, the term I'd use is persistent physical symptoms. So symptoms that last longer than someone would like. And that might mean they might be symptoms of a diagnosed long-term health condition, things like diabetes or irritable bowel syndrome or chronic pain. Or they also might be symptoms that maybe don't fall neatly under one of those headings, but are still giving someone a lot of kind of day-to-day discomfort or pain, or just not having a good impact on how they want to live their life. And I work with people to help them understand all the various kind of biological, psychological, and social ways and factors that could be all intermingling and having an impact on their health and these symptoms. Understanding that, and then thinking about, okay, well, how can we interrupt some of these cycles to hopefully reduce the severity and the frequency of these symptoms and help you live better alongside them, or hopefully get rid of them altogether. Yeah, it's work I really enjoy. And it's it's a nice balance to have NHS and private practice. There's a good mix in there.
And as a health psychologist, what would a kind of typical intervention look like? And I appreciate maybe that's a silly question because there isn't such a thing as a typical intervention. But what would be some of the approaches that you use most often?
Yeah, I think that's an easier question maybe within the scope of my practice, where and I can answer that quite easily, I guess. Where it becomes slightly more broad and multi-leveled is if we're thinking about health psychology as a discipline overall, because health psychologists can work in kind of clinical practice like myself, but they could also work in local governments or public health, or they could work in universities and academia. And as much as we're all maybe called the same thing and use the same title, we have very different jobs and we'd have very different we'd call on different skills within our overall kind of competencies, I guess. But for me, working with someone, I would usually adopt one of our kind of therapeutic models. So I would do quite a lot of work with cognitive behavioural therapy, sometimes acceptance and commitment therapy. I'm currently completing an additional training course in compassion focused therapy, which I am absolutely loving, as much as it's a tricky juggle alongside everything else.
You're so busy.
Yeah, but that is, it's quite, I was a bit worried about kind of going back to being a kind of a trainee again, but yeah, it's feeling really exciting actually, which is lovely. So yeah, I'm using a lot of compassion focused therapy, or CFT, at the moment. And one of the reasons I love that as a model, and I think it fits really well within clinical health psychology, is because it has a really strong foundation in evolutionary science, and it's a very, very biopsychosocial model. And that big long word, I know you know this, Jenny, forever, I guess for the benefit of everyone watching, is thinking about the biological, psychological, and social influences of our health, be that physical health or mental health, but also thinking about how our interventions in therapy have biological, social, and psychological outcomes. So CFT really works from a premise of everything we do with someone, every part of therapy should have an impact on the body. And for someone living with persistent physical symptoms, obviously that's going to be mega important. So yeah, I'm really enjoying CFT. I feel like it's one of these models that, you know, you come across and you're like, yes, that is how I work and that's how I think. And so I'm feeling really excited by that.
Oh, that's really nice to hear. If we jump backwards to the beginning now, I started off doing these interviews kind of starting at the beginning with people, but I don't know, maybe it's that, maybe I'm influenced by some of those movies where you get a bit of the story and then you get the origin. Kind of seems to like maybe makes a bit more sense. Where did it start for you? How did you know you wanted to be a psychologist?
I don't think I did until maybe kind of 4 or 5 years into psychology, studying psychology. I feel like I kind of stumbled into my undergraduate kind of wanting to go to university, but not really being sure what I wanted to do. I initially applied for medicine.
Right.
And in hindsight, I'm very glad that I didn't get into that, because I think, having now worked with a lot of doctors, yeah, I'm glad. I've got a lot of respect for all the hoops they've got to jump through within their training. But yeah, I think I am a lot happier that as a psychologist than I would have been as as medical doctor. But I think that kind of probably did inform why I went into health psychology and why I chose eventually. So after my undergrad, I took some time off, and then started my master's in health psychology. And I think the reason health psychology seemed like it kind of was for me was for a bit of that balance between the kind of psychology and kind of medicine and the body, and really thinking about how the body works. For me, it was that kind of amalgamation of the two. I had the interest in how our body works and how it's influenced by lots of different factors, but I also understood that knowing that wasn't enough. And just because we know how the body works, that's not enough to change it, and medical interventions aren't always going to be enough. We need a kind of that kind of holistic mix of things.
Yeah.
And I think I'd also kind of been very conscious of hearing stories from friends and families of when they'd had interactions with healthcare professionals or healthcare systems, and they had just been, I guess from their perspective, kind of told to make changes, kind of go away and lose weight, and then you can have that surgery, or okay, off you go and, you know, get those blood sugars under control, or, oh well, you know, your mood is low, kind of go and improve it. And it always struck me as kind of, well, what's, because people naturally, very understandably, found that very hard. And I was always very curious as about, well, what's going on there? Why do we find it hard to do the things that we might think or know are going to help us? And kind of, and also, why do we think it works just to tell people? Because kind of what's going on there? And I think that has improved. We've got a better understanding now of kind of the complexities of change. But that was the kind of initial thing that kind of probably led me to study my master's. And then after, and I think it was probably at that point I realised that I wanted to work with people and I wanted to work clinically. And we're very lucky in Scotland to have a fully funded training programme for health psychology. At the time when I was when I was coming to the end of my master's, it was the only funded route in the UK. I don't think there was even university courses, doctorate programs for health psychology. There is now 2 in Scotland and a number in England. I'm not sure about Wales and Northern Ireland. And they now do have a funded route in England. But at the time, I certainly felt very fortunate that I could apply for the NES course. So that's funded by and I was then placed within NHS Tayside, which is one of the health boards in Scotland, and had various kind of experiences and placements throughout my training, which gave me a nice real mix of experiences, both working with people directly and clinically, but also working in settings like public health, and doing kind of training with healthcare professionals, and a little bit of kind of developing and moulding services. So yeah, it was a really good experience, but ultimately led me to being like, I know that the kind of health psychologist I want to be is working with people and working therapeutically, and working to improve their kind of quality of life.
Yeah. So how long did your training take? So you'd done the masters.
Yes, I had. Well, in Scotland we do a 4-year undergrad, but I had such a nice time that I took 5 years to do that. And then so 1 year a master's, and then the kind of last bit of my training was 2 years. So,
Okay.
So what's that, 5, 6, 7, 8? Well, 2 and a bit years actually for that last bit of training. So I qualified after that, and then I stayed in Tayside afterwards for my first qualified post, which I was very happy to do.
Yeah. I was realising as you were talking that I wasn't clear on the health psychology training route. So, and it's interesting, I guess, like clinical, it's a lot of NHS funding, which we know can vary between the different nations in the UK.
Yeah, there's lots of different routes into qualifying as a health psychologist. So the route I did was, as I said, funded through the NHS, but I guess adopted the BPS, so the British Psychological Society. It adopted their independent training route as the means to qualify, whereas other training programs will go through a doctorate program at a university, and that's obviously independent of the BPS. Or you can also train as a health psychologist in the UK completely independently, and kind of, if you've got a job that's relevant to health psychology and provides you with the skills and experience that are relevant to the qualification, you can sign up to the BPS's qualification, and then you need to kind of get your own supervisory team in place, and you can train as you kind of go, and it usually, I think, takes a bit longer, that route, but that would be a truly independent route if you wanted to train and shape your training exactly how you want it. I mean, yeah, hats off to people who do that route, because I think it takes a lot of organizing of your own supervision and your own coordinating supervisor and things like that. But it is a very flexible training route because there is lots of different ways to do it. But yes, funded ways are more limited, but there is some, which is great.
Yeah. I am finding it really interesting seeing how, I didn't realise how different the training routes are to becoming different kinds of psychologist. It's interesting seeing some of the different flexibility.
In a way, so straightforward for clinical psychology training. It's the deep one, and that's the only way. It's kind of very palatable. It's very easy to explain to people.
Yes.
Whereas I think for other routes, be that health or educational or forensics, it's a bit more like there's more flexibility, but that makes it a little bit harder to maybe kind of give a elevator pitch on.
Yeah. And I know that when I first set up the YouTube channel, I shared a couple of links to sort of the BPS and another, it was an NHS focused sort of psychology professions link. And you're making me think I'm going to revisit those and see what they cover, see if there's other ones that even include a broader range of information. As well as obviously people need to do their own research, don't they? We can't give them everything.
And I think that things, I would love to think that as much as the flexibility I think is a great thing, I think sometimes I think the training routes do need to continue to update and continue to develop to meet the needs of the workforce, be that the NHS or academia. And I think the BPS are doing a bit of a review of their qualifications at the moment, including the health psychology qualification. So it'll be interesting to see what happens there.
Yeah. So coming back up to your sort of day-to-day life as a health psychologist, what are the bits that you enjoy the most?
I mean, that's an easy question, because for me, the bits I enjoy the most is when I'm sitting in the room with my patient. That's the bit that gets me excited and that I really feel that kind of, really feel that passion for. And I guess that's not always the easiest bit, especially within a forensic setting where our patients have often been through a lot to be in that room. They've experienced a lot of significant trauma in their lives, as much as they have maybe been the perpetuators. No, that's the wrong word. Perpetrators, that's the one, thank you. Perpetrators of violence. They have often often been the victims themselves at times. And that can have a huge impact on how readily they will trust someone and how they can form relationships. Oh, that's my delivery, that's Jenny.
No problem, you go and get it. Yeah, see you in a minute. Rather than stop the recording and then forget to start it again, I'm going to just reflect a little bit while we wait for Alison to come back. I haven't worked in forensic services, but what she's saying absolutely strikes a chord with what I would expect to hear, that people that have committed violent offences have usually experienced significant trauma themselves, have not had great life experiences.
Typical.
She's back. That was very quick. Alison warned me before we started recording that she was expecting a delivery, and I just was carry on talking rather than pausing the recording and then forgetting to start it again, and just mulling over. This is a population who, I'm saying I haven't worked in forensic services, but people that have experienced awful trauma and neglect, and developed unhelpful ways of coping and reacting to that. So not always easy then to form relationships with, not always well placed to engage in psychological interventions.
But as much as that is sometimes a really challenging part of the job, it's also so rewarding when you can form that secure attachment with someone and provide a really kind of secure base for them to trust and engage with therapy. And I find that just so rewarding, and so I think it's just such a privilege to be able to model like what a safe relationship within the context of therapy is for people, and it provides when that kind of goes that way, it's such a lovely way to then set up therapy and hopefully lead to some really positive change. And I think that applies quite differently within kind of more community-based work, whether that is working in the NHS in the community or within private practice, but it's still the bit about my job that I love the most. And I think as well, because that provides the space to get really quite like nerdy and geeky at times. Like I love to dive into the research and that kind of specifically about how mind and body meet and how mind and body interact with each other. And I really like trying to explain that to people in really kind of creative ways. And in ways they can understand, because that is, I think, that psychoeducation can be so powerful and such a powerful intervention in itself for people to understand how their body works and understand why they're experiencing these certain symptoms or why change is really difficult. And I think that can be really normalizing and really, really de-shaming for a lot of people. And I've had a few people who have we've done the psychoeducation as part of formulation, and they've said, oh, actually, now I know that, that's me. Like, I get it now. Like, I don't, and kind of that's been a bit of a light bulb moment for them. And then all of a sudden, it kind of therapy seemed a lot less daunting because or they've maybe I've had one once. I remember having a patient when I was a trainee. And taking her to supervision and being like, I'm not sure what I've done, but like after 2 sessions, she was like, I'm fine now, I'm good. Like I don't need therapy anymore. And all we'd done was psychoeducation about the gut-brain axis. This was in the context of IBS. And actually all she needed was, and I went to supervision being like, oh no, yeah, what did I do wrong? And my supervisor was like, nothing, that's just what she needed. She just needed to understand why she was feeling this way and why her body was doing these things, and now she's got that information in a way she understands. That's been enough for her to make these changes on her own and to improve all of these things. So but in my anxious trainee brain I was thinking, oh no, she's DNF. It's not she's not DNF, she's then DNA'd, and what have I done wrong? But
so you didn't know yet, did you? And I've had, again, as you're talking, I've got different clients I've worked with over the years where I suppose the way I think about it is before they have that psychoeducation and that framework for understanding what they're struggling with, often they're adding in layers and layers, aren't they? So I'm thinking of somebody I worked with who was experiencing symptoms of post-traumatic stress disorder. Because he didn't know what PTSD was, he then was worrying about all of these symptoms that he was having. He thought he'd gone mad. He thought he was a terrible person. And once I explained to him how trauma can affect us, you could just see. And he came back to the second session and he was like, oh, I've been feeling so much better already. And I think, without that, and probably even more so with physical health symptoms, we worry about them, don't we? If like, what is this that's going on in my belly? Is this something? Do I need to go to the hospital? Am I making a fuss about nothing? Like, there's this kind of attributional process, isn't there, as we're trying to understand it.
And people are naturally drawn to an information source that they feel can help them to understand this. But often the internet is filled with misinformation or information that just perpetuates that anxiety even more so. And or kind of gives them, or they adopt kind of a way of understanding that maybe doesn't actually capture what's going on in their own unique particular body as well. So
That's so interesting. So if those are the most enjoyable bits, what are the bits that you find hardest about your work?
I think the most frequently difficult thing I can find is working within the kind of the healthcare system itself. And I love working in the NHS, but sometimes I find it really difficult. And I can find it, frustrating and infuriating and but then it's also all these fantastic things as well. But sometimes the kind of bureaucracy of it, the slowness of it, the inflexibility of it can really, I don't know, can just really niggle at me and kind of wear me down, because there's a better way of doing things, or a more efficient way of doing things, or a way of doing things that would probably ultimately benefit the patient more. But we have to work within the scope of, I guess, whether it is security within forensics, or whether it is policies and systems and things like that. And yeah, that's one of the things that I can frequently struggle the most with, and is probably one of the things I reflect most of about in supervision. My peer supervisors probably sick of me coming with that. But yeah, that's one of the things. And I think ultimately that was one of the things that kind of prompted me to take on some private work as well, because I guess what I wondered was, would it be all the great things about my job I like, but with a lot more of that kind of personal ownership and a lot more flexibility, because I could set my own rules, obviously within the scope of things that we have to do to respect confidentiality and all those things. And I think it's been a really nice balance to have, and it's probably kept me more motivated within my NHS job to have kind of my Fridays as a day where I am my own boss, and I can set my own hours, and I can take a 2-hour lunch break in the sunshine if that's what I want to do. And that's, it's definitely helped kind of buffer out some of those challenges that I can feel sometimes from the system.
Yeah. Shifting gear a little bit, what's something that people sometimes misunderstand about what you do?
Ooh, and I think because health psychology is a relatively smaller discipline of psychology, I think there can be a lot of a lot of assumptions that are maybe made without us present or without us in the room. And I think we probably do, as a discipline, sometimes struggle to have our voice heard because we're not at the table. I think the thing that I can find is probably most common is that we are kind of a discipline of psychology who maybe only focus on behavior change, and that's all we do. We're very behaviorally focused. And we are armed with techniques to change behavior and change behavior alone, without the wider appreciation of all the different cognitive, biological, social factors that underpin behavior. And I think that can, for me, be the thing that I maybe have to kind of provide education to people about the most. Because, I mean, we wouldn't get anywhere working with patients if we just went in with the sole behavioural focus. We need to consider all the underlying beliefs, be that the beliefs that ping in and out of our minds every day, or these kind of really deeply held beliefs that drive and shape our behaviour. And they're obviously influenced by, don't have to tell you this, by so many different factors. I also think that there can be a bit of a misconception that as health psychologists, we don't work with mental health, and that we only work with physical health. We're obviously not medically trained. We're not doctors. We can't prescribe. We can't recommend treatment for physical health conditions. But I think sometimes that can be confused with, well, it means we can't work with that crossover between mental health and physical health, whereas that's our absolute bread and butter. And there's going to be, because there's a huge prevalence of anxiety, low mood, trauma within people who experience long-term health conditions, persistent physical symptoms, because they are people just like any other people, and also the burden of those physical symptoms make that more likely for some people. So yeah, that's probably the things that I would be most likely to kind of say if someone was unsure about what a health psychologist did. But also, it's, again, I've mentioned this before, it is quite difficult in a way to also say that, because there is lots of different types of health psychologists around, and some health psychologists don't work clinically with patients at all. They work in academia, or they work in settings like public health. And as much as these factors are all very relevant still, they're applied in different ways, and they're not applied in therapy, they're applied within the science and the shaping of interventions on a level bigger than that kind of one-to-one in the room intervention. They're kind of shaping community programs, or they're shaping groups, or they're shaping policy. And so it's a real strength of health psychology that we are so diverse, and that health psychologists can work in so many different places. But I can also find it a bit tricky sometimes to then give that kind of 30-second, this is what we do, because you're automatically going to be excluding one of your colleagues. And I guess all I can do sometimes is talk about the health psychologist I am, and what and kind of and the best guess at what all my my kind of colleagues in different settings do as well.
Yeah, you've really made me think, while we've been talking today, about that public health element to it. I'd thought about, the direct work with clients or with patients, the academic, the research work. And I keep coming back to thinking about obesity while we're talking. I've worked in a weight management service for a few years, quite a long time ago now. And that made me think about the complexity of, the eat less, move more message clearly is not effective.
Well, and not scientifically proven in the slightest.
No. And so I still kind of have a little ear out for, I love it when we hear about innovative ideas. And we could think about health psychologists, couldn't we, within obesity, working one-to-one or doing sort of group work with people who are struggling with obesity, but also looking at community interventions, and working on a societal level, working with government, and presumably an effective outcome would probably need work at all of those different levels, plus your academic and research colleagues.
But we also, I guess, what's also very relevant within not just within kind of obesity and lots of different areas, is also thinking about how healthcare systems need to change, and how the staff that work in healthcare systems need to change their own behaviour to best support people who live with obesity. Because you've hit the nail on the head there. There's so much. Weight's a really tricky area, because we all have a weight, we all have beliefs about our weight, and there's such big societal noise about weight, and there's moral value associated with it, and there's these huge kind of, we can really place ideals on people's weight and make assumptions about them on the basis of that, and that just makes it so complicated for them, us being in the room sometimes. And I think for an area of health that has had this very individualistic move more, eat less, I always confuse the two.
So much more appealing, isn't it, to think about eating more and moving less?
That is, and now we know that's just not what the evidence says. There's this huge biological driver of the disease process that underpins obesity, and that is now being recognised more with kind of, now there's so many more pharmacological options to help break that disease process through different medications. But we still need that holistic approach. We can't just give people medications and expect that to work. We need a lot of kind of wraparound support to help people deal with the to help people deal with the kind of almost these kind of really understandable hangovers of being stigmatized for so long because of
Yeah.
the shape of their bodies, which they've probably not had much individual control over.
Yeah. Yeah.
Also to think about the kind of ongoing change that's needed to then kind of live and adjust to this smaller body, because that can also have a big impact on someone's identity and how they fit in the world. I've worked with people who have lost a lot of weight, and I've said all of a sudden it's odd because people aren't looking at them or staring at them or kind of passing judgment on them, and that is lovely in a way, but also how odd is it? And it has this impact on lots of different areas of their lives. And
Yeah.
so yeah.
Yeah. Oh, I could talk to you all day about that. I'm
Oh, me
not going
too, me
to, because
too.
I'm sure you've got other things you need to be doing. I'm going to move on to my last question. What advice would you give to young people, or not even necessarily young people, but people who are interested in becoming psychologists?
Ooh, I'd say kind of that you should absolutely come and be a psychologist, join our gang. I'd say kind of spend time doing your research, working out, finding out all about the different kinds of psychologists you can be. Also, you don't just have to be a psychologist if you want to work within mental health. There's also all sorts of other disciplines and kind of therapist roles out there. But I think working out what's your why? What do you want to do with your career? Do you want to work on that one-to-one level with people? Do you want to work in a different setting? And I guess what's driving them to do that? Why does that matter to them? What values are they kind of pursuing in the to do that? And then almost using that as a bit of a blueprint to help guide them towards the different kind of training routes and different training paths. And I
Yeah.
guess
So what do you want to do? Why do you want to do it? What's the best route to enable you to do that? Because again, there's
yeah,
so much overlap, isn't there, between
so much over there.
so
Yeah,
when I've worked in a weight management service, obviously very, very similar work to work that you've done, and yet we're different kinds of psychologist.
yeah. And I think I definitely kind of over the years struggled with this sense of, I think because the majority of the psychologists I've worked with over my career have been clinical psychologists. And at times that's really led to this sense of imposter syndrome and this sense of not being good enough because I'm not a clinical psychologist and because I'm a health psychologist, because that is just it feels different and it feels and I think that's quite common amongst the kind of smaller disciplines of psychology. And I certainly have worked with my kind of health psychologist colleagues who've felt the same. I don't think it's I don't think it's true at
Not
all.
just you. Mm.
But oh no, it's definitely not just me. But I think one of the things that and I've obviously had lots of discussions with colleagues in supervision over the year, and I think one of the things that I often remind myself of when that kind of voice pops in, which it still does, is I worked with a great consultant clinical psychologist when I worked in Dundee, and she was very pro skill mix, very supportive of all the different disciplines of psychology. And she often said, kind of, it doesn't matter what kind of psychologist you are, we're all applied psychologists at heart. We all have the same core skills as applied psychologists, and then we all have unique skills which separate us out into our various disciplines, but we're all also working towards the same goal, and that is to improve people's quality of life and their mental and physical health and well-being. And that kind of always rings true to me as kind of, it doesn't really matter what comes before our psychologist. We're all in it for the same reasons. And we all have there's lots of similar skills we have, but we maybe look at things through slightly different lenses at times. And that's the benefit of having a lovely skill mix within teams and services, and that's why we have all these different types of psychologists as well.
Yeah.
So yeah, so that's maybe, I guess, advice to the future generations of psychologists as well, is to not worry if you don't want to go down a kind of the well trodden path, which for me was always sold as clinical psychology. And it's okay if you want to kind of go down other paths, and take your time making that decision as well, because there's no rush, and once you qualify, that's you, and it almost gets better after that, I think, because you get kind of you're over the you're over the really, I don't know, the initial scary bit, and you can kind of really
Yeah.
flourish after you qualify, and really kind of find out, kind of continue to grow into the kind of unique psychologist you are, and work out what that looks like for you.
I love that. I think that's a really good moment to pause. So thank you for giving me your time today. I'm going to
Thanks, Jenny.
stop recording.